Welcome to the 28th Annual Respiratory Health Symposium. My name is Melanie Langille. I'm the President and CEO of the New Brunswick Lung Association. The New Brunswick Lung Association offers bilingual services. Today's event will feature both English and French speakers and simultaneous translation. You can select the language of your choice near the bottom of your Zoom screen. There's a small globe-shaped icon that says interpretation to experience the program entirely in the language of your choice. If you make no selection, you will hear the presentation in the language of the speaker. Bienvenue au 28e Symposium annuel sur la santé respiratoire.
Welcome to the annual symposium. I'm Melanie Langille. I'm responsible for the association. We offer bilingual services to this event. We'll have Anglophone and Francophone speakers with simultaneous interpretation. You can choose the language of your choice at the bottom of your screen on the globe icon to follow in the language of your choice. If you don't choose a language, you will hear the floor.
This event would not be possible without the support of our sponsors. I would like to thank Boehringer Ingelheim, Merck Canada, Pfizer Canada, Hoffman La Roche Limited, Sanofi Pasteur, and Vital Air for their support in providing this continuing education session for respiratory health professionals and students. Cet événement ne serait pas possible sans le soutien de nos commanditaires. Je tiens à remercier.
This event wouldn't be possible without the support of our sponsor, Engelhart, Pfizer Canada, Hoffman La Roche Limited, Sanofi Pasteur, Vital Air, who help for the organization of this training session for the professional of pulmonary health. I thank our speaker for today, Dr. Margaret Herridge, Dr. Shelly McNeil, Amanda Babineau, Lacey, Sutherland, Courtni, Soucy, and Lynn and Duffley.
Je tiens également de vous remercier d'avoir pris le temps de vous nous joindre aujourd'hui.
Thank you for taking the time to be with us today.
New Brunswick Lung Association supports respiratory health in New Brunswick through education, research, and advocacy. We're celebrating a couple of recent successes, including implementation of a comprehensive flavor ban on vaping products, introduction of an electric vehicle purchase rebate to reduce air pollution and take action on climate change, and supplying nearly 700 homes with radon gas detector kits last year. We have a number of free resources that are available for respiratory health professionals and their patients. You can check out nb.lung.ca for free resources, including we have an updated asthma brochure that was updated with the most recent CTS recommendations. We have updated influenza infographics about new coverage for, for influenza vaccines for New Brunswickers that are age 65 and up. And we also have a new coalition called Health Professionals for Action on Climate Change, which I'll speak to a little more later. And now at 8:41, I've gone over my time already. Let's pass it over to Barb to introduce our first speaker.
Well, good morning, everybody that's now here, 263 at least of you. So our first speaker is Dr. Margaret Herridge. Yeah, no, I'm going to have to look away. Sorry. Our first speaker is Dr. Margaret Herridge. There she is. She is a professor in the Department of Medicine, a senior scientist in the Toronto General Hospital Research Institute, and director of the Recover program / Grace Recover LTV program, and most recently co-leads with Dr. Angela Chung of CANCOV, which is the Canadian Multi-Center one-year follow-up of patients and caregivers with after COVID-19. She has received several international research distinctions, including the Dr. F. Margaret Hill Lecturer, honorary member of the European Society of Intensive Care Medicine, Lifetime Achievement Award in Critical Care from the American Thoracic Society, the University of Toronto Eaton Scholar Researcher of the Year Award in 2019. And then the Deborah Cook Mentorship Award from the Canadian Critical Care Trials Group 2020. Dr. Angela Chung, who I've had the pleasure of meeting on another symposium. And so welcome, Dr. Herridge. I just want to briefly say Dr. Chung was going to be a speaker, and she was unable to. But I would like to mention, of course, and recognize her. She's a professor of medicine and Betty Ho Chair in Integrative Medicine at the University of Toronto and senior scientist at the University Health Network. She obtained her degree from Johns Hopkins University School of Medicine in 1988 and her PhD from Harvard in 1997. She is the co-lead of CANCOV, as I mentioned earlier. She's also a fellow of the Royal College of Physicians of Canada and has been in clinical practice for over 30 years. So now I can see why Dr. Herridge said you get up at 5 in the morning. You must have 48-hour days. I believe you for sure with all of this going on. So welcome, and we look forward to your talk.
Thank you very much, Barb. And I take responsibility for my time zone challenges. So I'm sorry to be joining you folks a little bit late, but hopefully can still offer some interesting insights on COVID. Barb, thanks very much for your call this morning and reminding me as a Torontonian that I'm a bit confused about time in New Brunswick. And I'm generally in a bit of a blur these days with all the critically ill COVID-19 folks. So not an excuse I should know the time zones, but my very sincere apologies. And thanks for your kind and gracious understanding. And I just wanted to say that I am here on behalf of both Angela and myself. Angela and I have worked together for many years. And we're also personal friends. I'm sorry that Angela couldn't be here today. We often do these talks as a tag team. Angela is a general internist. I'm a critical care physician and a respirologist. So we have a very complementary perspectives. I hold Angela in very high regard, and I'm sorry she couldn't join us today. So I'm just going to share my screen with you folks, if that's okay. So I'm going to talk, I was invited to talk by Barb and by the New Brunswick Lung Association on the post-COVID-19 condition research on the long-term health effects of COVID-19. And again, thank you very much for the kind invitation. It's a pleasure and a privilege to chat with you folks today. I just wanted to briefly introduce our CANCOV program. Angela and I, as I mentioned, have worked on different research projects in the past. We are co-leading this project. Angela's leading the ambulatory and hospitalized non-ICU cohort, and I'm leading the ICU cohort. And we have a number of centers involved across Ontario, Quebec, Manitoba, Alberta, and British Columbia. And we have over 100 investigators. So happy to chat more about this at the end, but right now I'll just try to head into a bit of a review of the literature. At the beginning of this talk, I wanted to add that I don't have any conflicts of interest to declare, and I have no relationship with industry. I'm going to give a very brief overview of COVID-19, very brief overview of outcomes after SARS and ARDS, some of the early emerging outcomes data for COVID-19, a brief description of the post-COVID-19 condition, a couple of highlights from the report from the Scientific Roundtable that both Angela and I are involved in as advisors to the province of Ontario currently, and brief comments on COVID-19 rehabilitation. SARS-CoV has an interesting biology in that it uses the SARS-CoV receptor ACE2 for host cell entry. And the spike protein of SARS-CoV-2 is primed by another molecule, the TMPRSS2, and this is what facilitates its entry into host cells across multiple organ systems. Early on in wave one, we understood that there were multiple stages. This has changed a little bit with some of the different COVID variants, but early on in the time course, there was the initial infection. Often people presented to medical attention because of abnormal chest imaging and subsequently elevated inflammatory and cardiac biomarkers. And the propagation of multiple organ dysfunction and organ injury. And you can see in this nice schematic, this is from the Ontario Scientific Roundtable, that there are really multiple organs affected by SARS-CoV-2. And this is because the ACE2 receptor is represented almost ubiquitously. And you can see all the organ systems here and all of the various effects that one might understand in terms of the current discussion about the post-COVID-19 condition. Now, I'm just going to briefly outline some earlier data from our group's one-year ARDS outcome study published in the New England Journal in 2003, and one-year SARS study led by my PhD student, Kathy Tansey, related to the SARS-CoV-1 outbreak in Toronto. And just to make a couple of brief comments, in our Toronto ARDS program, we saw that patients with the acute respiratory distress syndrome, and this is the severe manifestation, pulmonary manifestation of COVID-19, that even at 1 year, those patients who survived ARDS still only had 66% of predicted 6-minute walk distance. So people had important functional disabilities still 1 year after ARDS. And after SARS, and these patients in our cohort were not completely comprised of critically ill patients. A lot of these were hospitalized or ambulatory patients that even still at 12 months, the median 6-minute walk time was just above the lower bound of normal, but there were many patients who still had functional disability. So that signal of functional disability in the ARDS and the SARS literature already to help inform us about COVID-19 outcomes. And here, the pulmonary function outcomes from our ARDS study and from our SARS study. The ARDS study showing at about 6 months, the majority of folks having normal spirometry and lung volume measures, still a persistent reduction in diffusion capacity and similar findings to 1 year. And you can see that their pulmonary function testing in the SARS cohort was similarly showing good recovery at 6 and 12 months. So some early instructive data. Just like to highlight in the hospitalized and the critically ill patients that these are patients who are often immobilized. And there's a very robust literature on muscle and nerve injury in acutely ill patients, both those who are hospitalized and those who are critically ill. And these injuries of muscle really involve very specifically a myosin depletion myopathy and an axonopathy. So the axons are discretely injured as part of this severe illness. And this is one important contributor to the functional disability that I just outlined. It's a nice schematic from the New England Journal of Medicine from a review paper by Jesse Hall and J.P. Kress from 2014. And other morbidities, just to highlight, and this is germane to the discussion coming up about COVID-19, that patients after critical illness in particular have cognitive dysfunction and cognitive dysfunction independent of age and on the order of mild Alzheimer type dementia and moderate traumatic brain injury. They develop very severe mood disorders, anxiety, depressive symptoms, post-traumatic stress disorder, persecutory delusions, PTSD. There are different constructs, syndromic constructs of the chronic critical illness or post-intensive care syndrome, and also exacerbation or development of new frailty. Patients may also have the development of multimorbidities, and you can see here, these are all morbidities from our Recover program 1 year later, where patients have pressure injuries, shoulder contractures, complex back dressings, and a lot of cosmetic concerns. So a whole constellation of features that there's a robust literature on for the last 20 years and anticipating that we may see some of these issues in the COVID-19 patients. Now, here's the initial description of COVID-19, and this is from Wuhan. This was a cohort of over 1,000 patients, younger group, mostly men, a small proportion in the ICU, a small proportion who died. Ground glass opacifications from the lung injury, very common, and also low levels of lymphocytes, lymphocytopenia. Here's an early report from Italy by Carfi and colleagues showing, showing the persistence of symptoms, fatigue, dyspnea, shortness of breath, joint pain, chest pain, and cough, and that these symptoms are going on following the acute infection. This is a report early on of COVID-19 in Brazil. I showed this slide. It's a really lovely paper by Ottavio Renzani and Fernando Boza, showing how vulnerable populations have really been disproportionately affected in COVID-19. And we've certainly seen this in our CanCove study and many other groups internationally. We see that women typically are more affected than men. Patients with more comorbid illness, burden of comorbid illness, people who are less formally educated, people of indigenous background, racialized groups are much more vulnerable. And really important to highlight how COVID-19 has really shone a spotlight on health inequities, which sadly also exist in Canada, but certainly exist to an even greater extent around the world. Here's some early US data, 60-day outcomes. This is from the Ann Arbor group, from Hallie Prescott's group there. And I show you these data at 60 days to show you the financial impact in our American patients. And 2 months later, you know, a very large proportion of people saying they're at least mildly or moderately affected financially. So we can only imagine the financial burden on top of all of the health issues, the new health issues that many of these patients have sustained. Here's some French data from the comeback study. These were published in JAMA. And I just draw your attention, I already introduced some themes of functional disability, decreased 6-minute walk distance, and you can see that here across the severity of illness, there's a decrease in distance walked in 6 minutes. At 4 months, still a persistence of ground glass opacification on CT, some normalization of the PFTs that I also showed you, persistent reduction in the diffusion capacity, and very important signal in terms of cognitive complaints and impairments, symptoms of anxiety, depression, and post-traumatic stress disorder. Here's some 6-month data from Bin Cao's group. Bin Cao is the leader of the cohort studies that have been conducted in Wuhan, the follow-up studies. And he very nicely showed in this 6-month outcomes paper from published in Lancet, how the vast majority of patients had at least one symptom from COVID-19. There were issues with fatigue or muscle weakness, sleep difficulties, alopecia or hair loss, persistent anosmia or smell disorders, and sometimes some cardiac complaints manifesting with palpitations. And you can see in Bin's cohort here that again, there's this important signal of mobility issues, challenges with activities of daily living, difficulties with usual activities, high proportion of patients with pain or discomfort, anxiety, depression, decrease in quality of life. And very important signal again in reduction in distance walked in 6 minutes. Many of the patients at 6 months still had mild changes in their spirometry and their volumetric measures here by pulmonary function testing. And persistence here at 6 months still of ground glass opacification and at least one abnormal CT pattern. You might be interested to know that just a few weeks ago, Bin Cao's group published their 1-year data. So they are the first cohort to publish 1-year data. We will probably publish our CanCove data within the next, I would say 4 to 6 months. And of course that makes sense because COVID went from east to west. So we'll see the data emerge in this direction. And at least in Bin's cohort here, you can see that a lot of their group returned to original work, but that a significant proportion, almost a quarter, did not return to their pre-COVID-19 level of work, and that a significant signal here was due to decreased physical function. Now, both Angela and I were serving as consultants to the COVID-19 Science Roundtable, and you might be interested in reading the formal document. I've put the link here, but this is a good summary document. There is no question that there are sort of a multitude of symptoms across multiple organ systems, at least 10 organ systems that have been associated with the post-COVID-19 condition. This is the terminology that's been put forward by the WHO group. I served as the co-chair for the WHO group for the post-COVID-19 condition. And I think that the WHO is looking for opportunities to create a common nomenclature so everyone's talking about the same issues going forward. And I would just highlight that some of the most prevalent symptoms include fatigue, shortness of breath, general pain or discomfort, anxiety, and depression. So we see some physical symptomatology and also important mood disorders. The risk factors for post-COVID-19 are ongoing in terms of under study. We hope, Angela and I hope that we'll be able to contribute a lot of this through CanCove across the severity of illness, ambulatory patients, hospitalized non-ICU, and ICU patients. The potential risk factors, there's an emerging signal for, based on the WHO brief, include higher body mass index, being female, being older. So we see a signal here in terms of vulnerable patient populations having more acute symptoms or having more severe COVID-19. There's no question that this will represent an important public health issue going forward and internationally. And the WHO group reported that at least 1 in 4 individuals who are infected with SARS-CoV-2 will experience symptoms for at least 1 month, and 10% will have symptoms lasting beyond 12 weeks. And this is really the consensus time in terms of timing for the post-COVID-19 condition. So there are a lot of documents emerging trying to track this in real time. The National Institute for Health Research has a really wonderful dynamic review ongoing, where this is a review in time of the evidence around ongoing COVID-19. And I highlight this for you, and this is a wonderful reference document. This is talking a little bit about some of the mechanistic aspects of COVID-19. And I also highlight the Stanford Hall Consensus Statement for Post-COVID-19 Condition. This is another great reference. This is I really like this document. This is a very interprofessionally based, rehabilitative focused document across multiple organ systems. I've highlighted just a couple of aspects of it here, looking at recommendations for psychological rehabilitation and more general medical rehabilitation. I think it's very important to emphasize that these patients have a very high signal for anxiety, depressive symptoms, and PTSD, as I mentioned, and that it's important to divorce this or dissociate this from the perception that this is somehow, imagined or a somatization disorder. COVID-19 affects multiple areas of the brain, including the limbic system, and the mood disorders may indeed represent end organ injury from the viral infection itself and specifically brain dysfunction. And there are a lot of medical issues associated with COVID-19. I illustrated some of them. We're seeing signal across the emerging outcomes literature, very similar in many ways to the SARS-CoV-1 literature. And in the critically ill people, the folks that I've been, looking after for the last over 18 months, all the tragedies of this and all the disability that follows the critical illness patients, the signal there for disability and mood disorders and healthcare utilization is very similar to what we've seen in the post-ARDS patients and the chronically critically ill patients. So definitely lots to learn about COVID-19, but we're seeing the recurrence of a lot of signal that we already recognize. So I'm just going to give you a brief update on CanCove. We're looking at our data set right now. Angela and I just put in a grant. We're switching roles in this grant for the nominated PI for the follow-up of the second year and with an emphasis on vulnerable populations. So we're hoping to extend our initial follow-up and create a little bit of focus on vulnerable populations. Some of the groups I mentioned to you: women, racialized groups, socially disadvantaged groups, marginalized groups, people with an important burden of comorbid disease, older patients. So the Canadian government describes older patients as over 60. I don't think 60 is old at all, but there's certainly a lot of disability that we need to capture and help people with, and need data to inform public policy. So we're certainly hoping our work will be able to help with that. Thus far, you can see we're approaching 1,600 patients in this national multi-center study. We have a group of patients who are undergoing antibody testing. Our non-hospitalized cohort community folks, almost 600 people. The GIM patients at 274, the ICU patients at 283. And these are we're collecting a very granular, detailed data set. So we're really hoping to contribute these data to the international understanding of the post-COVID-19 condition. We have a website if you'd care to visit it. We're on Facebook and Twitter. And patients, as part of this study, can self-refer, because we're not just a research program. We felt very strongly that patients should be able to access us, and then we can act as health advocates and facilitate referrals. So this is really a clinical and a research study where we're trying to also offer healthcare intervention. And final thoughts to leave you with here: COVID-19 is a multi-system disease, and it's important to remember that there are a multitude of systems that are affected. There are very many similarities and differences from SARS and ARDS in isolation, and there's a historic literature that we can draw on. The post-COVID-19 condition, however, is unique. It's very prevalent, as I mentioned. Some early risk factors have been identified, and that list will grow. There's some current research barriers in terms of further delineation of the post-COVID-19 condition. We're trying to encourage robust core outcome sets, translational work. Our own group has a large translational and basic science collaboration group looking at multiomics and genetics. We're connecting with several groups nationally and internationally. And I just mentioned the aspect that we're really trying to focus on inclusivity. Early rehab recommendations are really focused on multi-system morbidities, with a hub as a sort of a more physiatry or rehabilitation interprofessional team focus. I really endorse that personally. This has always been the focus of our post-ICU recover program. And I think I'll leave it there. I want to apologize again that I got the time mixed up. You know, I am a little bit overloaded, I must confess, with my clinical load. So I do apologize. And I thank you for being so gracious. And I thank Barb for her persistence, all the back and forth emails and calls. I thank you kindly again for the opportunity to speak with you today. Thank you.
Thank you very much, Dr. Herridge. I know that you have to go, but I do want to say, no, it's again, okay. Thank you.
No, I don't have to go.
Okay. All right, good. We may
okay.
have a few questions. So we'll just open that up. You can ask your questions in your chat box, and then someone will, certainly lots of comments about thank you and very interesting. I know personally a very dear friend of my sister's in Alberta, so I appreciate this study. She ended up at age 52 on a ventilator and ECMO in Edmonton.
Really?
Yeah.
Oh, really?
And she survived, but just barely. Of the 30-some patients put on ECMO over the first year of the pandemic, I think only 13 of them did live. But she's also, of course, not also, she's experiencing some post-COVID symptoms, big time. And so this kind of research obviously is extremely important going ahead. That's obviously why I also asked you to speak, because I think it's the tip of the iceberg. I know there's a Facebook group with about 6,000 people in it.
That's right.
And so the more attention we bring to it, the more research to figure it out and then be able to treat it, because that's a common theme I've seen, certainly in that group, is where they were told that it was all in their imagination and they were just, you know, suffering
That's right.
anxiety after that experience. So look forward to seeing obviously more of this and the results for sure. And best wishes to Dr. Chung.
Yes, thank you very much, Barb.
Oh, okay, there you go.
A couple of questions coming up in the chat, Dr. Herridge.
Sure.
Someone is saying that they know
I don't have to go, but I don't want to also completely, I've already completely disrupted your schedule for the meeting.
Not at all, not at all.
You let me know, but I don't have to rush off. So,
okay.
And I just wanted to say, Miriam, or just before, or Melanie, sorry, you know, Barb, I'm very sorry that you have a close friend who's been through this. You know, we have a lot of ECMO people, like I would say our entire unit in Toronto at TGH was ECMO. At one point we had, I don't know, maybe 38 patients on ECLS. It was quite overwhelming for everybody. I would say we're all still reeling from that. And now we've got this new wave of 20 and 30-year-olds. I was just on call a few days ago. And our ECMO mortality at TGH was over 60%. And the patients were very young. And it is really, it is great. You know, this whole thing has been a really huge tragedy. And I would say, you know, if there's anything I can help, like we know all our national colleagues, right? If there's anything that I can do to help your friend in Edmonton, please let me know. I would say that the Organization for Rehabilitation and Outcome and Referrals, and this is something that Angela and I felt very strongly about, that we really felt we had a role as health advocates here because we are connected, we live within the system, we know about the disability, and we need the research data, but we also needed to really reach out and help people who are very vulnerable. You know, at a time when people are still learning about what the issues are and what we need to do about them and how to help. And there was this horrible initial overlay. And I remember giving talks then or being on meetings where people who were sick with mental health issues were just told to basically, you know, deal with it. I mean, it was pretty horrifying. And I'm glad that we've come around to openly acknowledge that this is a important and medical piece of having the post-COVID-19 condition. Forgive me, I just wanted to say a couple of those comments to legitimize that and to also say I'm very sorry that you're close to this. I think our whole ICU group at the General is pretty traumatized. I would say I feel completely altered by what the work I've been doing for the last 18 months. I'm not sure I've even processed it yet. And this last wave, last week, I was looking after 20 and 30-year-olds who chose not to be vaccinated, many of whom will die. And the moral distress associated with that is really something else. So we're all kind of feeling a bit overwhelmed here. And we need to do a lot of work, and there are a lot of people to help and a lot of families to look after as well who are also traumatized by this. So forgive me, but I just wanted to say that. And thanks again. So Melanie, please, how can I answer some of these questions?
Oh, sure. And thank you. We do have a huge appreciation for the amount of trauma that people on the front lines are experiencing, you know, dealing with COVID day in and day out. And I hope that, you know, over the next while you have some time to process and come to terms with what you've seen. And in the meantime, we certainly appreciate all the research that you're doing to help us, you know, move forward from this situation. We do have a couple of questions in the chat if you've got a minute or two.
Of course.
We've got a question about seeing several studies showing insomnia as a symptom of the post-COVID condition.
Absolutely.
Is there a correlation there? Yeah.
100%. So insomnia is a very common symptom. It's not in that sort of top flight group of symptoms that I was alluding to, but it's a prevalent symptom. And this also could be a manifestation of brain injury in some of the patients. I would say in the critically ill patients and Barb, perhaps your friend, I would suspect experienced this as well, that the patients on ECMO in particular are being subjected to polypharmacy. It's very hard to sedate them. It's very hard to suppress cough, because coughing really complicates the ability of the ECMO circuit to, adequately compensate for gas exchange. So people are, at least the critically ill folks as well, are also complaining a lot of sleep disruption. And this is related to the polypharmacy of drugs, as I said, also related to the fact that critically ill patients do not have very disrupted sleep architecture and have an enormous number of disruptions. I think the good news is that often the insomnia, it seems, at least in descriptive studies now, to dissipate a bit over time. But it is an important symptom, and people should seek medical attention for this, for sure.
Thank you. And you did mention that your research will be published soon, in the coming 3 or 4 months.
Well, it won't be published in the next 3 or 4 months. I would say maybe more like in the next 4 or 5 months, we'll put our data set together. And the process, the timing from beginning to clean a data set, to analyzing the data set, to writing the paper, and then going through peer review will probably add at least another 3 or 4 months. So I think what in the international literature that's sweeping from east to west, as I mentioned, and Bin Kao's group in Wuhan is the first 1-year paper. I think that, you'll see the North American data come out, start to emerge in about the next, 4 to 6 months. And the European, all the European literature will come out in that time. And you can see already, though, that the themes are very robust. The themes are not dissimilar to the SARS-CoV-1 literature, and also to the post-ICU outcomes literature for patients and for families. There'll be some nuances for sure, because this is a different entity, but I think we'll see some of the similar themes. And I think hopefully based on that historic literature can already begin to put together some rehabilitative, groupings, strategies. Barb was sharing the membership in the audience or the composition of the audience today. It is crucial that we work in interprofessional teams. I spend my entire day in an interprofessional team in the unit. I'm a huge supporter of our interprofessional colleagues and the importance, critical importance of their expertise on the team and what they bring to the team. So I think I hope one positive thing from COVID-19 will be that we start to think a little bit more about how we're organizing our health resources, and that we're organized more as interprofessional team structures rather than, sort of a physician lead or seeing a physician or an interprofessional person in isolation. We need to be working in groups and really harness the expertise from everybody as we look after patients with all of these complexities. I mean, I could probably talk for hours about all of the literature, but it was just a brief snapshot today, but it gives you a sense of all of the emerging themes that we're going to be faced with in the next coming years, really.
Fascinating. Well, thank you so much, Dr. Herridge.
There is one question, Melanie. I know there's quite a few actually, but I just happened to notice in the chat box. And as I had said at the beginning, I kind of didn't want to go down that road within the symposium itself, but is there early data that can be shared with vaccine hesitant general public to encourage vaccine? So I'm not sure if that's a vehicle that your research will be used for.
Yeah, thanks, Barb, and the person who put that question in the chat. Well, I think that we are following maybe a few things. If I could just say, and I'm preaching to the converted here because all of you folks are highly educated and content experts on this. Maybe the first thing I would say is the best way to prevent having the post-COVID-19 condition is to not get COVID-19. And the only way we can really, and this is where all of the excellent work of all the lung associations in the provinces and the Canadian Lung Association, Barb, and all of the groups and leadership folks can help with. And we're very happy to work collaboratively with you going forward too, by the way, I should say, is the education about that there's a morbidity here that's not necessarily predictable, and how COVID-2 interacts with your own genome, your own constellation of health issues, your own vulnerability. It is not completely clear. So why take the chance? I would say that's one message from the Scientific Roundtable for Ontario that Angela and I and Fahad and others have been messaging. We do have many people who've recovered, and our current recommendation across the groups is to still be vaccinated, because the natural history of antibody persistence after an acute COVID-19 infection isn't completely clear. So we are recommending, after people are recovered, to get vaccinated. That's another piece that can be promoted sort of highlighted. Now, the other piece is there are people who seem to develop symptoms rarely after vaccination. We have seen probably just a couple of people like this in CanCove. They are not serious symptoms. And we are tracking that as well. So, and we'll be very transparent about that. I think it is important to understand that the vaccine is still, it's been extraordinary how it's changed the dynamic of this, thank goodness. But we're still learning about it. I think the benefits clearly far outweigh the risks. But I think we're still trying to understand that. And there are the occasional patient who does seem to report symptoms after vaccination, after they've had COVID. So as I say, we're collecting all of this information, and we will report it and publish it. And, share it with our provincial and national communities, our international community, because every country's studies really need to be put together, and to get a real fulsome, more fulsome idea of what's going to, what the international community has faced, because different countries have different ethnicities, different genetic compositions, different healthcare systems, different vulnerable populations. So I think putting all of these different cohort studies together will also, we hope, be incredibly instructive going forward. So I hope that's helpful. But all of these data will eventually become transparent, will be transparent, and can inform, people's decision-making, and hopefully will further encourage people to join in supporting vaccination as an individual health issue, but also as a citizen and needing to contribute to public health.
Thank you very much, Dr. Herridge. This has been just a wonderful presentation. And again, we appreciate you being able to do this for us and fit us in. Certainly not only as a speaker, but we want to thank you, of course, for the work that you're doing as a researcher and as a doctor caring for our fellow Canadians.
Thank you very much, Barb. I really appreciate it. And I thank you very much again for the talk. And I'm really sorry that I got the time mixed up. I'm really I'm a bit running on empty these days, to be honest with you, and I'm getting a few things mixed up. But at any rate, thanks for being so gracious with me. Thanks for tracking me down. And thank you for allowing me to speak with you today. It's much appreciated, and very best wishes to everyone.
Thank you. Take care.
Okay, you folks too. Bye-bye now.
Bye. We're not really running behind. This is the nice thing. We've got a bit of flexibility here. And so the agenda itself has become a little bit jumbled. So Amanda, are you there?
Yes, I'm here, Barbara.
Just with being cognizant of the fact that you have to be able to wrap up and leave. Amanda's actually going to be speaking on her IPF NB virtual support group, but then she has to go and actually run one. She doesn't just talk about it. So I'm going to introduce Amanda next. And again, my apologies for having to read off to the side. I've known Amanda for quite a few years, and I'm very pleased to be able to have her speak today. So the title, of course, is if you're trying to see where you are on the agenda, it's the IPF New Brunswick Virtual Support Group 2021 and providing a virtual pulmonary rehabilitation program for patients, in brackets, for those affected by pulmonary fibrosis and their family. Just a quick note, because I know Amanda professionally putting this kind of thing on, and primarily because of the way things have developed because of the pandemic. This topic and the next one are, I think, really important as working professionals and those who are going to soon graduate, to know that technology actually stepped up, and that was wonderful to help us in these kind of patient and client care areas. And it's not going to go away, so get used to it. So Amanda Babineau is a registered respiratory therapist and a certified respiratory educator. She graduated from Canadore College in 2004 and began working as a respiratory therapist in Moncton and at the Dr. Georges Dumont Hospital. She also worked for 7 years in the pulmonary function lab before becoming a certified respiratory educator. She might be able to just quickly mention that in her talk if she hasn't got that in there. People might be actually saying, well, what is that? So she's now the coordinator for Zone 1B in chronic lung disease program management. So there you go, Amanda. Take it away.
All right, thank you, Barbara. So good morning, everyone. Because this is we're in a bilingual province and this is a new bilingual session, I will be speaking in French during the presentation. That you guys have access to the interpretation as mentioned before. However, my PowerPoint itself will be in English. I've actually never presented in French and had English words to look at, so we'll see how this goes. So, bienvenue tout le monde. Puis, hold on. There you go. Okay, excuse. Okay. Okay. Donc, je souhaite que tout le monde peut voir mon écran.
So I hope you can all see the screen. I'm here to talk to you about virtual care, education, and support. So today's talk, pulmonary fibrosis support and education group, is very informal as a session. We have 3 to 8 patients every month. It's still quite new. And since it's new, we don't follow a strict agenda for education. So people talk about what they want to talk about. I'll talk about our virtual pulmonary rehab education and some of our challenges also, and going forward in this virtual world. So I had to start from scratch. Before pandemic, I had a support group at Georges Dumont for persons with this kind of pulmonary fibrosis, so superficial disease. When the pandemic hit, of course, we stopped the in-person meeting. But after several months, we had to adapt and offer service, knowing that the pandemic was hard and person were isolated. We had to find a way to offer that service in some way to be able to meet. At the same time, we as educator at Georges Dumont, we're trying to understand Zoom, the challenges. I'm not very good at it yet, but the more we use it, the more we're good at it. One of the challenges we had was how to share what we developed, what we created. So at the Vitality Network, we have 4 zones. We all work together. Each zone has a respiratory health clinic. We offer the same services through Vitality to the various clinics. Once we created this document, I shared that with the Vitality educators. I'll also share on the Facebook page of Vitality. But what happened with this, anybody could find us. You did a Google search, pulmonary fibrosis support group, so you could access to our link. So with that, I had Americans who were logging on. So it had a different dynamic, and I still have an American that comes every month. It's interesting to see his point of view with the kind of services they have and the kind of challenges they have to deal with. Another way to see the group is through networking. As educator in New Brunswick, I'm part of the educators group. So in the recent months, if you're part of that group, you get a lot of email, and I send you a lot of PDF to be able to, that you can share with your clients. I also printed the poster with my phone number. I put them in the pneumologist offices. We have 5 pneumologists, and among these 4 have patients with pulmonary fibrosis. One day in Chantal, so one day was working on SBIT, and Chantal is another nurse who was representing OFAT medication, and it's for patients with interstitial disease, idiopathic and another indication. Anyway, so I discussed with Wendy and Chantal a lot. I explained the program to them, and they could share that with their patient, which were not a patient from the respiratory clinics, or maybe they were Mr. Rich that I use. I was in contact with CPFF, the Canadian Fibrosis Foundation, and anyway, the Canadian Fibrosis Foundation is for pulmonary diseases, and they have a Facebook page for all the patients. You can go on that site that you're looking for support group. You can find my phone number, my name, and all the information they need to reach me. So the CPFF, and here you have the support meetings, and you have New Brunswick, you go to Moncton, and now you can have all the information. For pulmonary rehab, at the outset, it wasn't a good idea to put a lot of these patients together who had advances in when we didn't have the vaccine yet, and we didn't have masks at the outset. So we put a stop to the pulmonary rehab. So in Georgia, we weren't able to give an indication because we had to deal with the lack of spaces, so we couldn't offer group session because of lack of spaces. So as a clinic, We went to the gym with the patient for the exercise, and we taught a one-on-one in the gym or in our office during the visit. When I created the support group for pulmonary fibrosis, I said, why not go ahead with virtual sessions? So with pulmonary fibrosis is limited, but education is more broad. So here it's more structured. So on the website, Living Well with the MPOC, we have access to Canadian PR program or rehab program rather. They already have PowerPoint that's already done, and we can use those PowerPoint. So that's where I find most of my material. It comes from these sites. I created a date. You joined today at 10:30 in less than an hour, and we ask help from other health sector. So I have a ergotherapist that will present on October 15 on energy conservation. I have someone that will present on November 5th for exercise. I have a dietitics that will make a presentation on December 10th on nutrition and lung health. And maybe that's not the right word. Psychometrists are. So I don't know that sector quite well, but it's a social worker from the area. She will present a session on stress management and anxiety. And once again, I create the pamphlet, I do PBF. When the PDF is done, it's a matter that you send it by email to the patient and they can click on the link they're interested with, so they can log in the meeting and they can register quite easily. But for those who know how this internet works, our challenges, the hesitancy or lack of comfort by the health professionals to promote these services, to share it with their client. Sometimes it's not that they're hesitant, but sometimes they forget. I see patients at the respiratory clinic, and we see a lot of patients, and we have other things to deal with, and we forget to mention that such and such a program is available. And as educator, we're not active on virtual session. We think that if we don't like it, maybe the patient doesn't like to do it either. So, but I appreciate any help I can get from you to share these programs with your patients. I mentioned it also, but the promotion of the program, if we create the program on pulmonary fibrosis, but the patient who doesn't access to us, how can she or he know this program exists? So I'm always open to new idea, but I think it's a challenge for me because I know there's a lot of patients that has those disease that are looking for help and they have questions. So how can we link the patient with the services offered? So that is still a challenge for me. And I repeat, the Facebook platform is okay, but it's not everyone that's on Facebook. There's a generation that's on Facebook, but the older persons are not on Facebook, you know. So the young person say it's for all people. So if it's on Facebook, as I repeated, everybody has access to Facebook throughout the world, and they can just log in. So this is an important topic. There's a patient who has internet at home. Maybe they're 70, 80, they have internet because their grandchildren gave them an iPad. But I was an hour and a half on a patient over the phone to help them over the phone to log into Zoom on his iPad. So all the apps and the challenge with the marker. I'm not an expert, so I find that part quite hard to do. And what happens, the older person who have problems will lose patience, and it's frustrating for us, and it breaks my heart, but that's all I can do. I asked them to come to my office, and even that didn't work. And somehow they have technology because it's older technology and it's not updated. So it can be a challenge to inform the patients of the services.
C'est ça. Une fois qu'un patient y accède, le Zoom.
Once the patient logs in on Zoom, you have to tell them how it works with the mute and the video. Sometimes his nose is right in the camera. Sometimes if I have a lot of patients, it's not a lack of etiquette, but rather a lack of knowledge. They always want to speak about themselves. If they have 10 other person, I try to move along. We're right off the track sometimes. So it's one of the challenges with Zoom, with this new technology. So how do you participate in these kind of sessions? And during the sessions, for pulmonary rehab, when we do group education, we always want to assess what the patient has learned. In Zoom session, you have several patients. It's harder to assess this. When I have time to do so, I want to do Zoom questions for the patients. But unfortunately, I didn't have the time to do it, and I couldn't finish that. So that's something I'm looking to do for the winter sessions that I want to create also.
D'où ce qu'on va à cette heure, je peux pas imaginer un monde à cette heure où ce que le Zoom.
I cannot imagine a world without Zoom. Now, it changes everything. The person who are participating in these sessions are from Edmonton, from the Cajun Peninsula, from Fredericton. So it allowed these persons to take part in these sessions. That's a good thing. But my patient from the other zones, they say, what is going to happen to us when you start the one-on-one meeting? I cannot let go my virtual patients, even if I do the one-on-one again. So I'll have to find a way to have a room, to have a patient in a safe environment, so to keep the contamination at a minimum, but also to be able to have the Zoom at the same time. I don't know if I should use my laptop, but to have a patient in the room, another on the Zoom platform, doing both at the same time. I would like to continue to have other care professionals involved, another health zone. And I think it's important when we teach something, what it's taught by an expert in the discipline is important. And I'll be able to involve other health zones and to work with Horizon Health and my colleague at Horizon with my other colleagues in other vitality zone. And who knows, maybe there are something else I can do that I didn't think about that. And that's true for everything you do. If we don't change, you will never be able to evolve. It's stepping outside our comfort zone that you begin to grow and transform. So we have a program that's well received. Thank you very much.
If there's any questions for me, I can answer them in either language. Je peux les répondre à n'importe quel langage. Merci.
Thank you, Amanda. Anybody has any questions for Amanda, you can go ahead and type them in the chat. I know, Amanda, you do need to hop off and do a session for your folks.
It's only at 10:30, so I have
okay.
I'm good. I'm good. I can answer if there's any.
How many sessions do you do in a year, Amanda?
Yeah, so pulmonary fibrosis is every month. And then for the pulmonary rehab, we did a winter session that went from end of January to beginning of May. And then this current session started on the 10th of September. And then it's going until December 10th. So we try to avoid summer and avoid Christmas. Because I get to pick the dates. I try to avoid Fridays of long weekends when maybe other people would be traveling, that kind of thing. And then whenever I want to do my next session in the winter, I'm going to have a look at the calendar. Maybe we'll go February to May, or we'll see. And I guess it's just to talk with some of my colleagues, maybe ask even the patients, see what their feedback is. If maybe no one likes Fridays, maybe I'll do a Thursday. But yeah, it's usually pulmonary rehab is usually 2 sessions a year. And then patients who miss one, they can come up to the next one. They can come all the time if they want. I really don't mind.
And since you've pivoted to virtual support, do you find that you've had more attendance or less, or is it sort of the same?
So for the pulmonary fibrosis, I've had less attendance. I feel with the pulmonary fibrosis is that it's a scary disease. It's a very isolating disease, so people wanted to be together, and it's in an older population as well. By older, I mean I shouldn't say older, but they're not my young asthmatics, and that's kind of what they were looking for, is that person-to-person contact. So there's been a lot of hesitancy with that. So right now it's just a small group, and it's just really talking. We just kind of get together once a month. We just chat. My last session, there was only 3 participants, and I was going to cut it short, and then one of them brought up something about a PFT test. So I decided to explain exactly how a PFT test is interpreted to the patients, and they took notes. They were so interested. So it was very, we just improvise as we go along. We talk about topics. I'm sure one of our next topics will be about the 3rd COVID vaccine in certain patients. So we just kind of see what's in the air, and then we just talk about it.
Well, that's great. I think you have the potential of reaching more people virtually if you can overcome the technology hurdles.
Yeah,
because you eliminate the travel, right? So
yeah, and can get people to promote it more. This would be fantastic. So
yeah, we can definitely help with promoting it. And best wishes as you go forward with it.
Thank you.
Thank you, Amanda. That was really informative. And just to speak to very quickly, having supports in place because of the pandemic. We have a lung transplant support group that was already well established for years on Facebook. And so we were dealing, of course, with patients who during lockdown couldn't go to Toronto when they were supposed to for their transplant. So again, as I say, this whole concept of technology, social media, virtual webinars is crucial going forward, and will continue to be a big part now in our healthcare portfolio for everyone. Thank you. So our next speaker, she's disappeared, so she can make a grand entrance maybe. Our next speaker actually is our CEO, Melanie Langille. And Melanie is going to be speaking on the implications of air pollution and climate change on chronic lung disease and infection. So Melanie is an environmental scientist with a background in human health risk assessment and contaminated site assessment with a specialization in vapor intrusion assessment. Melanie began her tenure with the New Brunswick Lung Association as the Director of Program Development, Environmental Health, and brought to life a long-term vision for the organization of the Foundation for Resilient Health. She brings to the organization a strong science background with a bachelor's degree in biology and a master's degree in environmental science, a passion for knowledge sharing. Her previous experience in environmental and human health risk assessment, environmental impact assessment, and contaminated sites management gives her a unique perspective on the importance of the environmental and social determinants of health. I'm not sure if this actually is in here. I don't see that, but Melanie has taken over as our CEO as well. So she has lots on her plate. So Melanie, if you'd like to go ahead.
Thanks, Barb. Let me just share my screen here. Bear with me as I get oriented here. I find it really confusing sometimes when I see myself in the corner. There we go. All right, so thanks for the introduction, Barb. And as she said, I am the current president and CEO of the New Brunswick Lung Association. You may be familiar with my predecessor, Barb McKinnon, who waltzed off into retirement in July and handed me the torch. So thank you, Barb, for that. And let's talk about air pollution and climate change. Overall today, I'm going to talk about sources of air pollution, what the Air Quality Health Index is, how climate change affects air quality, how that affects our lungs. And if I have time, I know we're trying to squeeze a little bit here, I'll talk about what the New Brunswick Lung Association is doing in all these areas. Major sources of air pollution can range from a wide variety of things. It's not just industrial facilities. There's a lot of air pollution related to transportation. When you think about the gas or the diesel that you burn in your car, that is a source of a number of pollutants. Electricity generation, less so in New Brunswick. A lot of our electricity generation is non-emitting sources, but for areas that do use a lot of coal for electricity generation or burning of other fossil fuels, that spits that stuff into the air. Metal refining, cement is a big one on a global scale. Combustion of anything, really. So I have fossil fuel and transportation. It's kind of double dipping there, combustion. Wildfires, we saw a lot of wildfire smoke this summer in New Brunswick that was brought to us from other areas. And so that's called transboundary movement. So we're affected, our air is affected not just by what we do here in our local area, but also what is going on in other parts of the country, the continent, the world. Those pollutants can get moved around really quite alarmingly easily. And when we talk about air pollution, talk mostly about nitrogen dioxide, particulates, small particulate matter, and ground level ozone. Those are the ones that cause the biggest issues to lungs. And of that, we put a lot of emphasis on particulate air pollution. Graphic here on the right shows relative size of particulate matter. Usually we're talking about PM10, which is particulate matter smaller than 10 microns in diameter. So that's dust, pollen, mold, those sorts of things, which can be irritating to the lungs. And then also PM2.5, which is even smaller. Combustion particles, organic compounds, can be small flecks of metal, and these can be inhaled really deep into the lungs and can actually be transported into the blood and transported about the body. So these are a couple of areas that can release particulate pollution. Forest fires are pollen seasons, particularly in the spring when you see that your car is completely covered in yellow. You know, those are particulates about 10 microns and they are respirable. Wood burning from furnaces, wood stoves, campfires, wildfires, of course. Construction, the dust that is generated during construction activities is particulate pollution. Agriculture, the same thing, and fossil fuel combustion, of course. And these can be emitted locally or transported over long distances. So I wanted to introduce you, if you're not familiar with the Air Quality Health Index. It is a really helpful and informative index that was developed jointly between Health Canada and Environment Canada and a number of stakeholders, of which my predecessor, Barb McKinnon, sat on the committees to help with the development of this. And so it's a calculation that takes into account the cumulative and relative risks from ground level ozone, particulate matter, and the nitrogen dioxides, and forecasts them for the next day. So in addition to checking the weather to see if you should, wear a raincoat tomorrow, you can actually check your AQHI before you head out and before you plan your day. So you can get this AQHI index on weather.gc.ca. They are working towards having it integrated into the Environment Canada weather app that you can have on your phone. It's not there yet, and I hope it comes soon because it is really important, particularly if you're living with lung disease. So the scale goes from 1 to 10, 10 plus, that's a very high risk, which we see sometimes in very close contact with wildfires. I grabbed this screenshot last week of the AQHI forecast for a number of areas in New Brunswick. And as you can see, generally we are low risk, 1 to 3 on the AQHI index. What does 1 to 3 mean? They actually have this messaging that is available for both the general population and the at-risk population. So you can see 1 to 3 is a low risk for both the general population and the at-risk population. But as the AQHI goes up, as that risk gets higher, we consider more and more preventative measures for those that are already dealing with lung disease. So what we like to tell patients that live with lung disease is to watch the AQHI and kind of monitor their own symptoms and know where their triggers are. So we have people that have a lung disease, but they are generally fine at an AQHI of 5, but a 6 is going to cause them a lot of extra issues. We have other people that are fine at a 2, but it's a 3 that they have an issue with. So it's an important little piece of knowledge that can help you with planning out your day and your next day, because we do forecast it in advance. When we talk about climate change, there's a number of different factors that come into air pollution. So the heat increases the production of ground level ozone. Ozone is a production, it's a chemical reaction that happens in the air, and O3 is really quite damaging to the lungs. We have longer growing seasons, longer pollen seasons. You may have heard people say that they've had worse allergies this year than they had when they were younger, and it's not just perception. This is a real thing. It's documented. Longer growing seasons, longer pollen seasons, more intense pollen seasons are affecting those of us with allergies. And these warmer conditions makes the world more hospitable to mold and mildew. So if you have allergies to those as well, this is becoming more and more of an issue. All this heat is also causing more intense wildfire seasons, like we saw this summer. Extreme wildfire events in the western parts of our country, wildfires across the country, and movement of that smoke, that air pollution, not just in the area of the fire, but also out east too. We were seeing that. Hot, stagnant air means that pollutants that are emitted into the air don't dissipate out into the upper atmosphere the way that they would otherwise. They're more trapped, they're close. And so that increases our exposure to these pollutants. And the high humidity also holds those pollutants near to the ground, near to where we're breathing, and can cause a host of lung concerns. So what we're seeing and what we're predicting with climate change is elevated morbidity, more hospitalizations and mortality directly attributable to air pollution. So Health Canada right now quotes that about more than 15,000 premature deaths in Canada are attributable to air pollution, pardon me. Exposure to air pollution can be a chronic level exposure or acute. But those that are exposed to chronic air pollution are going to have the more issues. Things in the air that can bother the lungs include particulate matter and the nitrogen dioxides. It's also environmentally persistent free radicals get in and cause physical and biochemical damage within the lungs and can be transported further away. All those particles getting into the lungs, all that pollution causes an inflammation response. So it kind of is a slippery slope of increased response to irritants. You can have bronchoconstriction. Particles can actually be retained in the lung tissues. Some of them are small enough that our normal responses to coughing them out is just completely insufficient, and so it continues to irritate as it's in the lungs. And that can lead to cell damage and death. And there has been some evidence of epigenetic effects too. So changing in the expression of your DNA that can be inherited further generations down. When we think about air pollution exposure and children, there's two ways that children can be exposed. The actual air pollution that the mother is exposed to while the baby is developing can affect the fetus, can also affect, can lead to low birth weight, premature death, or premature birth, pardon me, and disturbed development of the immune system. So everything that's going on in the womb with the developing lungs, the developing immune system can be interrupted if the fetus is in a polluted environment. We know that children have rapid breathing rates, and their burden of pollution is higher relative to their body weight. They've got small bodies than it is for adults. So they tend to have disproportionately high exposure to pollution. And we have seen that children exposed to air pollution, either in utero or as a young child, have decreased lung function and increased incidences of asthma. When we talk about air pollution in respect to diseases, things get really interesting when we start to talk about COVID-19. In general, exposure to air pollution is going to put more stress on the body, which is going to leave you more susceptible to viral infection. But the particularly interesting part, and Dr. Herridge alluded to this earlier, that the ACE2 enzyme is a receptor for the COVID-19 virus. A body's response to PM 2.5 pollution leads to upregulation of ACE2 production. So you actually end up with more receptor sites. And same with NO2 in the respiratory cells. So exposure to pollution causes changes in the body that will make you have more receptor sites for the COVID-19 virus to get in and penetrate into the cells. And so we've seen this. There's lots of studies that will correlate highly polluted areas with higher frequency and severity of COVID-19 cases. We think of places like China, Italy, New York City. This tracks a heavily polluted area. Could be one of the factors in the high frequency and severity of COVID-19 cases. We are a little bit skewed on our time. If someone could send me a message, tell me what time we want to be, done here. I can't see the messages actually, so I'm going to keep going for another 5. Air pollution in New Brunswick is monitored by a number of air monitoring stations. So this image was taken from a Government of New Brunswick website. I forgot to quote it there, but it's easily available if you check for New Brunswick air quality stations. The purple ones and the red ones are different. The red ones are in place by the Government of New Brunswick as part of the National Air Pollution Surveillance Program. The purple ones are put into place by industry as part of their approval to operate through the Department of Environment. So you can, at any time, go on and check what the air quality is at these different stations on the GNB website, and they produce a report yearly that talks about any exceedances of guidelines over a period of time. It's not in real time though, so the most recent report reflects on 2019. In Canada overall, we pride ourselves on pretty good air quality. But still at that 32% of Canadians live in areas with poor air quality. And this is based on a study published by Health Canada and Environment Canada in 2020. So we say 15,000 premature deaths annually attributed to air pollution. Now that it's important to note that's based on the 2020 standards. And so in this graphic here, you can see the black is the concentration of particulate matter, fine particulate matter over time in Canada. And the red is the Canadian ambient air quality standard, the CAQS. So that standard right now is set at 10. We've been progressively ratcheting that down over time. So the 2020 standard is actually 8.8. So that line's a little lower. So our concentrations are a little higher to what we would consider the upper limit of healthy air. But what's really interesting right now, you may have noticed earlier this week, the World Health Organization has slashed their guideline from 10 to 5. So when you go back here, and if we thought about a guideline of 5, which actually doesn't even show up on this graph, that's showing that everywhere in Canada that has been measured since 2000 has unhealthy levels of particulate matter. So that'll be something interesting to watch going forward. And there's new research actually published early this year that has estimates of fossil fuel related deaths of particulates specifically attributable to fossil fuel burning at about 34,000 deaths a year in Canada. And that's compared to what Health Canada has been quoting for years of 15,000. So all that is to say that particulate matter, we're understanding it more and more as more of a threat than we had understood before. So there's an urgent need to reduce particulate air pollution. Now, I do have a couple of slides on what the New Brunswick Lung Association is doing, but in interest of time, we'll stop and have our 5-minute break now. And if there's time at the end of the session, we've got some time for survey and wrap up. I can sing our praises and talk about what we're doing, some really interesting projects on the go, but I will cut it short here for now so we can have a 5-minute break. Go ahead, Barb.
No, actually, I was basically going to just say what you're saying, which is, yeah, we'll take a 5-minute break, and then Lacey Sutherland will be coming on. And I do feel like we're on one of those little hurry up and go treadmills, but we're doing pretty good for time.
Okay,
right.
So 5-minute break. So we'll be back at 10:15. And Dusty, you had a nice splash page to put up while people step away for coffee. Welcome back, everybody. Hope you had a good break. We do have a couple of questions in the chat about attendance certificates. So if you require a certificate of attendance today, after the session, you can send an email to Barb Walls, and I will put that in the chat here right now. If you are a student, you will get your certificate through your instructor, okay? Non-students, feel free to email Barb Walls, and students, please hold off on emailing Barb Walls because there's a lot of you. I'll pass it over to Barb now to introduce our next speaker.
Thank you, Melanie. Just to mention, so we do have a general certificate of attendance for the MBCC students, a general certificate of attendance for RNs, and then continuing education credit one for the RTs, and the LPNs also have a certificate. All right, so our next speaker is Lacey Sutherland. Our topic is a virtual support group for people living with COPD. It's offered in Nova Scotia and New Brunswick, and we've worked collaboratively with Lacey to encourage New Brunswickers to take advantage of this as well. Lacey has a Bachelor of Science in Health Promotion from Dalhousie and is the operations coordinator at the Lung Association of Nova Scotia. Through her time at the Lung Association, she has developed a passion for lung health bringing awareness to the importance of protecting our lung health and supporting Nova Scotians impacted by lung disease. There you go, Lacey.
All right,
No,
thank you.
no pressure.
All right. There we go. All right, let's just get situated here. Perfect. So thank you to Barb for the intro and to New Brunswick Lung for having me today. I'm very excited to discuss our virtual COPD support group. As Barb mentioned, I am the operations coordinator with the Lung Association of Nova Scotia. Just a quick background about us. We are a charitable health organization dedicated to improving quality of life by preventing and managing respiratory disease through advocacy, patient services, education, and research. Very briefly, COPD is chronic obstructive pulmonary disease. It consists of two major breathing diseases, chronic bronchitis and emphysema. Most people who suffer from COPD actually do have both of these. There is no cure for COPD, and it does get worse over time, but it can be treated and managed, which is where our COPD support group comes in to help manage that. So we started our virtual support group in October of 2020 during the second lockdown. Nova Scotia also does have very high rates of COPD. We have about 5.9% of the population compared to the national average of 4%. Our support group just offered a way for people to connect, ask questions, and receive education and expert advice, especially in a time during a pandemic when it can be really challenging to get that information and education. It's also another way for those to get some social connection in a time when social isolation was definitely a big challenge as well. So our primary audience and demographic for our support group is older adults, just because typically COPD does start later in life. Not always the case, but for the most part, our members typically are from mid to late 40s, all the way to late 70s, early 80s. We have members from across Nova Scotia in both urban and rural settings, but we are open to members from all across Canada. We do have members in other provinces. It's a great thing about having a virtual setting. We can reach a lot of different people. I did also want to mention that we do have several members that have other comorbidities that impact their quality of life that we try and take into consideration in our discussion and education as well, and how that impacts their COPD. To join our support group, about 98% of our registrations are through our online form. Typically, you can reach that in our paid ads, in our social media posts, but it's also on our website. For those who aren't online, you can give us a shout, and I can or an email, and I can register you right then and there. Once you're registered, you receive our welcome guide. We have our COPD support group guide, which just gives a little bit of background on our us as the Lung Association, how to join Zoom, as well as what you can expect in our meetings. Once I have sent you your welcome email, you will get our invitation to our next support group session, about the topic, the speaker, the link to the Zoom meeting, and then you'll get subsequent reminders and follow-up, but I'll get into that a bit later on in the presentation. How we promote our support group. It is primarily via social media, through paid advertising. We typically start that about 2 weeks out from our group. We've played around with that a little bit, starting about a month out, a couple of weeks, but 2 weeks is when we get the most engagement. We've also promoted it to respiratory clinics, pharmacies, community health teams and boards. We're using posters, leaflets, rack cards, just to spread the message that we are here to support those with COPD. But majority of our participants have heard about our group via Facebook, through our paid ads. But as we continue to go, actually more and more people are hearing it through word of mouth from our other members, which is really great to know. We do use Zoom as our platform. It's very user-friendly. That's something you have to consider when dealing with typically an older adult population. As well, it has the ability to record the presentation portion of our meeting. That way we can post it on our website and YouTube for anyone who missed a session, anyone who's new to the group and missed it, or anyone who wants to go back and review the information. That's becoming more and more popular with like our medication videos, so that anyone who changes their medication or inhaler can go back, review that information to make sure that they're getting the education that they need. It also increases accessibility. We have participants all the way from Sydney, Cape Breton, all the way down in Digby, and across other provinces too. So that's a great thing about having virtual. We can really reach a lot of people. As well as Zoom, you know, older adults, there's definitely not everyone's comfortable with it. There's definitely some fear and distress, which is great because you can call in and listen that way. As well, you don't have to have your video on, so you can still access that information depending on your comfort level. So my communication method with our members, it's primarily done via email. I include information on our upcoming meetings, and that would be our topic, the speaker, link to the Zoom meeting. As well, I have reminders, emails about 1 week out, a day out, and the day of our meetings at our members' requests. Sometimes there's a little forgetful, so it just makes sure that they can access it as well, a little easier. And then after our meetings, we have a follow-up email. I try and get that out within a week after our meeting, which includes highlights, key discussion points, any requested resources they want, anything that they want in there, I will make sure that I access that. As well, when we have education presentations, I will give an email update and a link to that as well so that they can review that information whenever they want. Other ways that we communicate with our members and members between themselves, we have a private Facebook COPD support group. They can ask questions, have discussions, whatever they want. We share news articles, as well as I give updates about our meetings as well to that way for them as well. We also have email communication options for those who aren't on Facebook. It's an opt-in option. So anyone who wants to communicate with others outside of our meetings, they just send me an email and I'll connect them with others. That way they can have a very good peer support group between themselves as well. So our meetings are typically an hour to an hour and a half long. We typically host some the second Tuesday of the month at 2 p.m. I try and keep this very consistent so it's easy for our members to schedule it into their lives, but I do have flexibility on this depending on our presenters' availability. We offer open discussions and education presentations alternating each month. This is at the members' request. They find that they can learn something from both of these formats. There's always something to learn from discussions with our peers, but also from experts as well. When we do have education presentations, they're typically 30 to 40 minutes. I record these with presenters' consent, as I mentioned earlier. That way we can record and post those on our website later on. I do have all questions held until the end. That way we stop recording. So any questions and any discussion afterwards is in a confidential, safe space. It's really important about this group to have a safe space where people can open up and discuss their COPD with one another. Our open discussion sessions are facilitated by a certified respiratory educator. She is an incredible resource to really bring in everyone into the conversation, as well as provide that expert education and advice to our members. We also have a respiratory therapist as well who joins us. She heard about our group and she was really liked it, so she joins us as much as she can, and she's another invaluable resource that we have for supporting our members. I really encourage member ownership of this group. This is their group. We want it to be what they want and what they need. So they're the ones who dictate the format. So the open discussion and education, that's what they wanted. So that's what they get. Whatever topics that they want for education sessions and the length of the meetings. So as long as they're still having meaningful conversation, we keep the meeting going as long as they want. It's really important that this is their group and that we provide what they need. Some of the topics that we've covered so far goes from what is COPD, mental health and isolation, pulmonary rehab, nutrition, advanced care planning, the what, when, and how of respiratory medications, yoga, breathe. And then we record these sessions. You know, people come back to the advanced care planning a lot, the what, when, and how of respiratory medications, as I mentioned earlier, about whenever they change their medications, an inhaler, yoga, breathe. I had really positive comments about that as well. You know, I had someone tell me that we did the session and then they went for their evening walk and they could breathe so much better. It was so much easier after having those stretches that we did. So that was really great to know that these education sessions are really having an impactful meaning on our members. I also just wanted to include a couple of impact statements from my members. I think this one little thing around COVID-19 in the past 18 months, not knowing if it was COVID or her COPD. And of course that would lead to so much anxiety, but like our group has really helped alleviate that. So that's really wonderful to know that we're having that impact, as well as the impact that we had around the advanced care planning and be able to have those challenging but really important conversations as well with our members. So that was great. And then just one more, her pharmacist, she led us to the Lung Association and our group. So that was great to know that our group is getting out there across Nova Scotia, and that it's through word of mouth, and that we've been really able to help this member through different education sessions, as well as the follow-up documents, because we do cover a lot of information as well. So having those follow-ups to just go back through the information, let it soak in. So it's great to know that we've also had a really positive peer support impact on this member as well. It's really wonderful to hear that this group is having a positive effect on anyone with COPD. And of course, our support group is supported by the Canadian Emergency Community Support Fund, as well as the Community Foundation of Nova Scotia. And I am happy to answer any questions that anyone has about my support group. Thank you so much.
Thank you, Lacey. I see that there is a question here. And, oh, sorry, someone did actually ask a quick question about personal support worker students. And so I'll just reiterate, the MBCC certificate is a general, so it doesn't have your name or what class you're in. It just basically acknowledges that you attended. So, and again, any students should be looking to their instructor for that. So here's a good question. Have you ever reached out to assisted living, excuse me, and long-term care facilities to see if their recreation departments could arrange participation for appropriate residents? My work experience is in long-term care, and I can think of so many residents who would benefit from this group.
I have not, but that is a wonderful suggestion, and I'm happy to connect as well. So that, yeah, that's a great suggestion, and we want to reach as many people as possible. So yes, definitely another great avenue.
So Sarah, if you want to email me, I could send you Lacey's email. Okay. And I just wanted to mention that Yoga Breathe that Lacey mentioned is a New Brunswick Lung Association creation, and we started that a number of years ago. And interestingly enough, again, the pandemic has helped make it a little more accessible, certainly for people with lung health challenges, trying to get out and about the house or out of the house and traveling. Before, when support groups were physical, right? People had to use up more oxygen, they had to use gas. So there is a lot of encouragement for these kind of sessions moving forward. And we hope to put on our Yoga Breathe again this fall. Oh, I see that Shelly's going to be with us shortly, so that's good. Any more questions? Because we are pushing things a little. So thank you so much for this, Lacey. I appreciate everything that you do. Oh, someone had a question. You mentioned that COPD is quite significant in Nova Scotia. That person kind of wants to know what that reason is.
There's a lot of reasons. We do have high smoking rates in Nova Scotia.
Exactly.
It's just a demographic. That is not my area of expertise. I am not a doctor. I'm just a facilitator for this, but there is definitely underlying conditions and social determinants of health that do impact our health and respiratory health as well.
Exactly. All right. Well, thank you so much, Lacey, and thanks for bearing with us. All the speakers.
Thank you so much to having me today. This was really wonderful and exciting to be a part of.
Good. All right. Thank you, Lacey. So I'm not sure if Dr. McNeil is actually here and ready to go.
I am here, Barb. Yep.
Oh, hi. Thank you so much. Well, let's just dive in, and you're good with this time right now. As you can tell, we've had to push things a little. It was a very, as the organizer, it was a little dizzying this morning, trying to get everybody.
Sorry to contribute to that chaos.
No, you didn't. No, it's fine. Trust me. There's been a lot of shuffling. Anyway, so today with us is Dr. McNeil, and she's going to be speaking on an update on Canadian COVID vaccine rollout, an overview on COVID-19 related vaccines, national attitudes, concerns, and results of the vaccine rollout. Dr. McNeil completed her medical education and internal medicine residency at Dalhousie University, followed by a three-year fellowship in infectious diseases at the University of Michigan in Ann Arbor. Dr. McNeil returned to Dalhousie in 2000 and is currently the Professor of Medicine and Pediatrics and Chief of the Division of Infectious Diseases at the Nova Scotia Health Authority. Dr. McNeil is a clinical scientist and Deputy Director of the Canadian Centre for Vaccinology, where her research focuses on immunization policy and program evaluation. Oh, I lost my place.
That's good enough.
Oh, is it? Okay. Yeah, there's another half a page.
Yeah, that's plenty. That's plenty. Thank you, Barb.
All right. Thank you. All right, let's proceed.
Excellent. So thanks so much for inviting me. A little chaotic in the COVID world, so I apologize for messing with your schedule. And I'm probably not going to talk about what Barb said I was going to talk about exactly, but so I apologize for that too. But I just wanted to give you a little update about COVID vaccines, largely focused on some of the sort of hot topics right now. You know, how well is the vaccine still working? Particularly, how well does it work against the Delta variant? Are we going to need boosters? When, if, how? And then the new recommendation in Canada, which has been implemented, I gather, in New Brunswick for a third dose in the primary series for people who are immunocompromised. So I thought I'd just go through a little bit of that, since that's a lot of the questions we're getting right now about the vaccines. And then I'm happy to take any questions that you have more generally than that. So that's my disclosures, none really relevant to this presentation. And I just reviewed the objectives. So both the Pfizer and Moderna clinical trials are now out. The participants in the original clinical trials that got these vaccines licensed are now out into sort of 5 or 6 months of follow-up from the original 2-dose series. Both of these mRNA vaccines are remarkably effective. These are amongst the best vaccines we have. You know, certainly in the adult vaccine world, efficacy rates this high are very unusual, almost unheard of. And, you know, if you think about influenza vaccine effectiveness, we're usually thinking about, you know, sort of 60 to 70% effectiveness against becoming infected with influenza, and about 40 or so % protection against getting hospitalized with influenza. So the COVID vaccines are both, these particular COVID vaccines are both much better than that, with out to 6 months effectiveness rates looking at sort of in the low 90% range for both Pfizer and Moderna. There is some question, though, as we see with any vaccine, about at what point, if any, will we see sufficient waning of the protection from vaccine that we'll start to see a drop off in that effectiveness. Most of us did not believe, and I think I'll show you that we're really not expecting to see a significant drop off in how well the vaccines work in this short a period of time. But there has been some early signals particularly from Pfizer, that there may be some waning of immunity. And that probably relates to the fact that these vaccines were developed very quickly for obvious reasons, not without, of course, the right attention to safety and regulatory controls. But they were dosed at an interval in the clinical trials that would be unusual typically. So we know that the interval between the first and second dose of any vaccine is important. And typically the farther those can be spaced apart, the better the immune response to the vaccine is. So they were handicapping themselves a little bit from the beginning with these vaccines by going with such a tight interval. 21 days, 3 weeks with Pfizer and 4 weeks with Moderna. So that's much tighter than we would normally give vaccines. You know, if you think about baby vaccines are usually 2, 4, 6 months. So we give at least a couple of months between that first and second dose to allow the immune system to respond. So perhaps not all that surprising that if you give the vaccines that close together, you've sort of impaired the long-term immunogenicity or immune response, and you might start to see a little bit of waning. But the question, of course, then is it important? You know, is this waning going to translate into increased clinical disease? So when we think about the effectiveness of any vaccine, you have to think about what outcome you're thinking about. So are you worried about preventing infection? Are you worrying about preventing symptomatic disease? Are you worried about preventing hospitalization? Are you worried about preventing death? And the effectiveness of a vaccine can vary on each of those measures. So in the case of COVID vaccines, we know that the effectiveness in the Delta era, we know that the effectiveness for the prevention of either infection of any sort, so serious or non-serious infection, symptomatic or asymptomatic, is lower than it was for the original sort of wild type strain and the alpha strain, but still reasonable as it's reported in England, Scotland, from many studies, and in Canada, where the effectiveness against the prevention of infection remains sort of in the 80-ish% range or a bit higher. That contrasts, though, with what's been reported out of Israel and Qatar and the US, where lots of concern was raised about whether the vaccines, whether the Delta variant had sort of escaped, so to speak, the ability of the vaccines to control it, because Israel started reporting rates of protection of only 39% against infection in their population. But I think that, you know, the general conclusion has been that these are quite different situations. So Israel, for one, Israel, Qatar, and the US all used that short dosing interval. And you recall quite controversially at the time, both Canada, the UK, and Scotland, amongst some other countries, used an extended dosing interval. And that was really based on the National Advisory Committee on Immunization assessment that the first dose was providing quite good protection against severe disease, and we had a limited vaccine supply. So trying to get as many people protected with the first dose as possible while giving a little bit more time for the immune system to respond to the first dose and then following up with a second dose a little bit later. That was very controversial at the time, but NACI has definitely been vindicated now. It's very clear from multiple studies, including these, but more, that that extended interval actually significantly improves the effectiveness of the vaccine, both for Moderna and for Pfizer. We do still have some concerns, though, because we do have populations within Canada who did get the vaccine on schedule. So in many provinces, we gave long-term care residents both doses close together because we were worried about leaving them susceptible in that period between the two doses. Healthcare workers in Canada were prioritized, and many of them got the vaccine on that tight interval. So in those groups that were vaccinated at the very beginning of the campaign, or those who, and happen to also be the people who typically got the shorter interval vaccine, we do have to worry about whether those people in particular will be likely to wane faster and need a booster sooner than other populations. But the good news side of the story is that if you consider the effectiveness of these vaccines against severe disease, we continue to see very high effectiveness, even against Delta, against hospitalizations and death due to COVID. So in Canada, 100% effectiveness reported out of a large study by Jeff Kwong. England, Scotland still reporting very high rates in the 90% range against severe illness. And even in the countries that used a tight dosing interval and started their programs before us, they're still seeing excellent protection against severe disease with both products. So that's very reassuring. But there have been studies to look at the impact of time since vaccination on the risk of infection. So these are what are being called breakthrough infections. So infections occurring in people who are fully vaccinated. And this essentially shows the rate of breakthrough infections per 1,000 vaccinated people, stratified by the time since vaccination. So they looked at a population in Israel that had been fully vaccinated by June, and they looked at breakthrough cases in late July when Delta virus was the only or the primary by far variant circulating. So that helps to look at not only the Delta effectiveness, but also whether there's any role for waning. And you can see that the further away you get, so the black bars were vaccinated back in January, the lighter gray were vaccinated in May, shortly before the study was done. You can see that you do see increased breakthrough infections and a decrease in effectiveness the further out you go from vaccination, ranging from sort of 75 down to 57% in the older population. But again, importantly, regardless of age, you can see that there was very little shift in the effectiveness estimates over time for severe disease. So a little bit of drop and not overlapping confidence intervals. So presumably might even be statistically significant, but definitely not as significant as a drop as we're seeing with infection. This is a similar study out of California, which again demonstrates sustained protection for, this is Pfizer vaccine out to more than 5 months after vaccination. And remember, that's about as long a follow-up as we have for anybody in the real world or in the trials, but does show, as has been shown in other countries, this waning of protection against both Delta and other variants, although it's more pronounced with Delta. So pretty clear we're seeing some waning of protection against infection, but not waning of protection yet against symptomatic or against severe disease. This study all looked at nursing home residents because remember I commented that they would be a population we'd be particularly concerned about, both because they are not likely to respond as well to vaccination in the first place, but also because they may be subject to more quick waning of protection. And you definitely see that the protection conferred against infection with Delta variant in the later period of the study was lower than would have been expected based on the original effectiveness estimates in this group. So about a 20% or so drop in effectiveness over that period of time. But it's difficult to say whether that is entirely related to waning or maybe related to again, some reduced effectiveness in this population against the Delta variant. We do in some studies see considerably better protection from the Moderna vaccine. It does have a higher content of mRNA or the vaccine product in it. And it does seem to translate into higher antibody levels and better duration of protection and effectiveness. But in this particular study, not any difference noted. This is really pretty much more of the same. Again, just showing that if you look only at infection, we start to see waning of protection or reduced effectiveness against Delta out to 5 months or so. But as you look at the more severe outcomes, except in those who are the most clinically vulnerable, so older adults with multiple medical comorbidities, outside of that population, we continue to see excellent effectiveness for the prevention of hospitalization. AstraZeneca overall is less effective than either of the mRNA vaccines and does seem to be subject to the same waning of protection against infection, but also has maintained pretty good effectiveness rates against severe outcomes. So lots of things to think about when thinking about whether to institute booster doses. Vaccine effectiveness, as I mentioned, seems to be lower in those countries that used a tighter interval and who started earlier. So it's hard to say, is that related to the time that they started and waning, or is it related to this tight interval? And lots of immunogenicity studies have been done to support that the likelihood is that it's dominantly driven by the shorter interval that was used between the first and the second dose. There are also, of course, it's difficult to control for public health measures because we know that vaccine isn't in itself enough to eliminate the risk of transmission of COVID in a community. So it's hard to compare countries because we don't know what else was going on in the country at the time. And then impact of indirect protection is also important, because you'll recall that Israel had very, very high coverage rates, as does Canada, the US much, much lower. So how much does that pressure of virus circulating in the community impact on how well the vaccine is performing? Again, this general mounting and consistent evidence that we are continuing to see protection against severe disease is supported by the immunogenicity studies, which did show excellent T cell responses and memory B cell responses with these vaccines. They induce a very brisk and robust immune response. So not that surprising to people in the vaccine world that we wouldn't expect to see waning against severe disease this soon. So that's all very, very good news. And then again, just a mounting evidence over time that Moderna appears to be a better vaccine, which is kind of interesting, because you'll probably remember back to when everybody thought Pfizer was the only vaccine they should get, and everybody sort of waited around to get Pfizer because for whatever reason the world had convinced them that it was a better vaccine, and ultimately it turns out that probably Moderna is a better vaccine in the long run. So, the US, you've probably been watching the news, which has been a bit crazy out of the US, as it always is. The US is moving quickly toward boosters. They are, Pfizer, the company that makes the Pfizer vaccine, has been pushing hard this data that suggests this waning of immunity. And the US, given its ongoing struggles with the fourth wave, have sort of jumped on the booster bandwagon and decided to start boosting. In some cases politically, they've decided to vaccinate the whole country again, but the ACIP and decision-making bodies like the CDC have been a little bit more measured, although not much. So they're broadly vaccinating much of their population. But I think it would be very difficult not to accept that the overall impact of the vaccine program to control COVID is really dependent on reducing viral pressure in the world and getting those first and second doses into the most people you can to reduce circulation of the virus broadly. I think if you've got 45% of your population vaccinated like they do in the United States, spending time boosting those 45% is not going to get them out of this mess. They really need to focus on getting the first 2 doses into people. And from an ethical perspective, is it ethical to vaccinate, to provide a 3rd dose to Western countries when most of the world hasn't had access to vaccines at all? Many would argue that it's not. But that being said, there will be some groups as we move forward in time where we will need to start to think about boosters. I think the obvious first population will be long-term care residents, because again, they were vaccinated very early in the course, and they were vaccinated in most provinces on the tight dosing interval that the company had tested. So those people likely will need a booster. The National Advisory Committee hasn't yet made that recommendation, but I wouldn't be surprised if we see a recommendation for boosters in long-term care soon. And some provinces have already moved forward with that. I'm not sure if New Brunswick has, to be honest. And then community dwelling adults, older adults, again, recognizing that they have waning immunity to any vaccine, they may be up next. And then there's ongoing concern about healthcare workers who, again, were vaccinated relatively speaking long ago, and were also mostly dosed on that short interval. So I know that NACI is reviewing the evidence of effectiveness in healthcare workers to decide if and when it might be necessary to give boosters to healthcare workers. But it's fair to say that there's no plan in the immediate future to offer broad boosters to the general Canadian population. So that's boosters, but coming back to optimizing protection, which is different than a booster. So the intention of a booster is to sort of recall, so you get adequate immunity with the first 2 doses, and that starts to wane, and then you boost people to sort of bring that immune response back up to a protective level. What we're talking about with immunocompromised people is really just optimizing the initial schedule. So while 2 doses works very well for most populations with these mRNA vaccines and the AstraZeneca vaccine, but largely we're talking about mRNA vaccines now, it's clear from immunogenicity trials and now emerging data about how well the vaccines work that people with moderate to severe immunocompromise don't respond as well to the vaccine, no big surprise, and that has translated into reduced effectiveness of the vaccine. So we are seeing more breakthrough infections in people who had 2 doses of vaccine but are immunocompromised. There have then, because since we're seeing that, of course, there's been lots of interest in, well, if you gave boosters to those people who didn't respond to the first 2 doses, will you actually get an immune response? And it's about 1/3 to 1/2 of people who don't have a good antibody response to those first 2 doses who will respond well following a 3rd dose and get protection. So the take-home message from that is, yeah, boosting them may well help, but there's still going to be a significant portion of that population that won't be fully protected by vaccine. So important to think about that when we do things like lift mask mandates, for example. And these people should be, and many patients with COPD, for example, who may be on oral steroids may fall into this group. And those people would, really should consider themselves to be not fully protected by vaccination and continue to take all the other measures to protect themselves. So again, in this setting, the 3rd dose is really intended to provide immunity in those people who just didn't respond well to the first 2 doses. It's not a booster, it's really optimizing the primary schedule. So NACI has recently made a recommendation to give a 3rd dose to optimize that primary series for people with moderate to severe immunocompromise. And they've defined that as active systemic treatment for malignancy. So not including, hormone therapy alone, not including radiation therapy alone, but chemotherapy and other therapies for active cancers. Solid organ transplants that are still requiring immunosuppressive medication, which is the bulk of them. People who have had CAR T therapy, which is brand new, so there's not very many of those, or have had a bone marrow transplant within the last 2 years. People with severe primary immunodeficiencies, and that's a big long list of unusual conditions that are detailed in the policy. Advanced untreated HIV, which many provinces or some provinces have translated to include people with HIV and a low CD4 count. I don't think New Brunswick did, though. I think they've left it at advanced untreated HIV. And then active treatment with a bunch of immunosuppressive medications. So high-dose steroids, high-dose methotrexate, any kind of biologic agent, many of the medications you would think of when you think of immunosuppressive vaccine recommendations, for example. And then I see that New Brunswick has added a couple of additional indications for this 3rd dose. So splenectomy or significant problems with the spleen, which arguably does not impact immunogenicity, but this was one that was a little bit controversial, I think, and there's a little bit of conflicting evidence. So I'm not sure exactly how the decision was made to add it in New Brunswick, but they have. And the other one that was very controversial that NACI did not recommend a 3rd dose in was chronic kidney disease on hemodialysis. And I see that New Brunswick has moved forward with that recommendation. So we didn't in Nova Scotia. In Nova Scotia, we sort of stuck with this top list, including people with HIV and a low CD4 count, but we have not added this group to our program. And there is some variability across the country, and particularly around chronic kidney disease. It's not uncommon that provinces have done that. Nova Scotia just didn't, and you guys did, which of course always causes some angst in patients, but that's where we are. And we may well get there, but for the moment, we won't be vaccinating those groups in Nova Scotia with a 3rd dose. So still lots of questions. We don't know how much antibody is enough antibody. So people, want to get, for example, get serology to see if they're immune to COVID. We don't have a test that will answer that question. We don't, you either have or you don't have antibody. If you don't have antibody, you may still have a good immune response, memory response if exposed to the virus. And likewise, if you do have antibody, we have no idea how much antibody you need to be protected. So serology is not a useful tool in figuring out if someone's immune to COVID. We don't know the duration of protection, getting more information over time that will inform the need for boosters. We don't know what's going to happen with COVID. mean, clearly clearly we've established that we are not in an endemic circulation. You know, we're not seeing it working like flu or acting like flu yet. But hopefully at some point we will get to a point where it either goes away, which is unlikely, or it begins to circulate just, you know, as flu does endemically in the community, and we get building immunity over time in the population. And then of course the most important question is this ever going to end, which I do not have an answer for. So that's all I wanted to say in that brief little snippet. Didn't want to go too long, and I'm happy to take any questions you have.
Well, the questions were streaming in, so we again, in the interest of time.
Do you want me to just flip through them and to say if I?
Well, I picked out some that I think would be nice to get a quick answer. I was thinking of in ways to make this, which I often do with patients who don't want to get the vaccination and prior to going to be listed for a lung transplant. One of whom did get his shots and is now home after his lung transplant.
That's good.
So one of the questions, and I think this is really important, and so we appreciate you doing this, because as healthcare professionals, I feel it's our duty to educate ourselves and to follow the tracks scientifically and the research. There's a lot of unfortunate misinformation out there. So one of the questions was, how do we know that the long-term effects, and I'm interjecting because I don't think there's any long-term effects with a vaccine. How do we know that the long-term effects of the vaccine will be safe in our bodies 5 to 10 years from now?
Yeah, so we always do long-term safety studies with any vaccine. These vaccines do cause an immune response in a slightly different way than normal. This concept of messenger mRNA, messenger RNA, is a new idea, although it has been used in many other vaccines and in other types of treatments, like for cancer and the like. But that being said, we know that the mRNA that we're using as part of the vaccine gets broken down very quickly in the body and disappears within, a week or two. So it doesn't last, and the only thing that lasts is the immune response, and that's the same as any other vaccine will do. There's no reason to believe that we would see long-term safety effects. And in fact, we've never seen long-term safety effects with any vaccine. So any vaccine side effect we see almost invariably occurs within the first few weeks to few months. And we've never in any situation had a vaccine of any type that caused long-term health impacts, aside from the good ones.
Thank you. And just to add to that, so I'm 70 and I've had every vaccine going since the 1950s, and here I am. Polio, smallpox, you name it. And some of those obviously were met with a lot of skepticism and concern 50, 60 years ago. Mm-hmm. And just again, to simplify it, and I don't mean to be condescending, but this is what I tell people. Our immune system is like our own army. And it's kind of hanging around going, okay, well, we're kind of ready for whatever comes our way. And then the vaccine is like a drill sergeant, and he comes in and shouts, hey, you need to get this special army ready over here because this bad guy's coming. And then that's what the vaccine does. And then he leaves. That's how I simplify it.
Yeah.
So if I'm wrong, let me know.
No, that's true. Yeah.
Yeah. So the next question was, and I think you answered it already, so I'll just mention it so I don't feel like I'm ignoring somebody, but you talked about natural antibodies and whether you actually needed a vaccine or not. What I heard you say is that even if you've had COVID, there is no, because this is all in real time, there's no evidence yet of how much you actually need to protect you from getting it again. And so that it's still recommended, right, that you get a vaccination.
Yeah, absolutely. It's likely that you have some at least short-term protection against COVID, but we don't know how much protection you have and how long it lasts. So the recommendation is it's not dangerous and it boosts any immune response you've had. So it's good to get both doses of vaccine regardless.
Right. And a couple of quick more, I hope. And I think that's a few more that might be coming in. But so I can see this happening. I'll be having to answer this question myself. If you need a third dose, and you've had Pfizer, of course, because Moderna looks more effective, should you get your third dose as Moderna, or it's fine to get either one?
Yeah, I mean, it's a good question. And I don't think anyone really knows the answer to that question. The national advisory guidance is to get the same vaccine if it's available, but that if it's not available, you can get the other one interchangeably. So I think it's a, I don't think the evidence is strong enough to say that you should get Moderna. I think, for most purposes, within a few percentage points, they're equivalent.
Okay, that's great. And someone's saying, thank you. This is the most precise update I've gotten so far. That's great.
That's what happens when your speaker's in a hurry making slides.
That's true. So I think you've answered quite a few of them about mixing doses and, which you should get next. And I'm just going to slide this up because I feel like there was. Oh, someone said that if they're not able, for whatever reason, to get get an mRNA vaccine, what do you recommend then as a COVID?
So it's a little bit of a tight spot because we don't have much AstraZeneca left in the province. So in some ways, it depends on why you couldn't get an mRNA vaccine. And if it's related to allergy, our allergists here have vaccinated many, many people with PEG allergy very safely in a controlled environment, had no episodes of anaphylaxis. So I would say there are very, very few people who can't get an mRNA vaccine. So I would try that route first, referring to allergy and trying to see if it's safe to get an mRNA vaccine. If not, there is a little bit of AstraZeneca left in Canada. There probably is a little bit left in New Brunswick, but I don't know the mechanism to access that in New Brunswick.
Okay.
And we don't have J&J yet.
Right. This is, I'm just going to mention it. It's not something we can answer now, nor could you, I think. But it's just about people trying to book for their third dose, and they couldn't figure out how to book it. But that being said, the government
just announced it today. So
they just announced it actually yesterday. I'm on Plaquenil, and so I'm a senior, so I don't know whether that means I should be getting a third dose, but I went and looked anyway. I'm just letting you know that you just have to go to the government website and be patient. As I said, this is all real time for the past year and a half, which is daunting, I know, and we're all pretty tired, but just persevere, and you should be able to find that. I've seen it in there somewhere, so you'll be able to find where to, but you should be talking to your healthcare practitioner first before you just go ahead and book, even though there may be a questionnaire. Just to make sure that you fit in one of the categories. Yeah. All right. Well, I think that's pretty well the main ones. And I'm sorry if I missed anybody, but I knew this would be an interesting particular topic because of the vaccines. And if we didn't get to anybody and you still have a pressing need to have an answer, you can certainly email me, and I'll do my best to find out the answer to that. So I think we're done. Melanie, are you there? Do you have anything to add?
Yeah, I'm here. We still have another speaker to go to.
Yes, right. So thank you, Dr. McNeil, very much.
Thank you very much. Enjoy the rest of your meeting.
Yes, you too.
Bye-bye.
Bye. All right, moving along. Courtni and Lynn, are you there? It sounds like a TV show host. Come on down.
This is Courtni. I'm here. I'm just not sure if Lynn might be in the meeting room. I'm not sure if she's here.
I haven't seen her name come up yet. I'm just checking and see if there's any urgent. What do you think about proceeding, Courtni? Or is this is a joint presentation? So, oh, she's on mute and no video. All right. Well, we're going to give her a minute or two, and again, this was, as I said, a very interesting topic. And I really do encourage all of you, as I said, it's your responsibility as a healthcare practitioner and as a fellow New Brunswicker to stay informed with the best reliable information that is backed by science and research in going forward and talking about the vaccines. As you can see from that talk today, it actually, all of it made sense to me. And that's good to know. So I see Courtni's back.
Yes, my apologies. I think Lynn will just pop on when she gets a chance. She's just running a little bit late, but yeah, I can certainly start.
Okay. All right then. So I'm going to introduce you then. So Courtni is a, so the title is Live Well, Bien Vivre, a Pandemic Wellbeing. And Courtni Soucy is a health coach with Live Well, Bien Vivre Health Promotion, Heart and Stroke Foundation of New Brunswick. She works to support and guide New Brunswickers through behavior change. I've actually gone through this program and it's excellent. She originally grew up in Grand Falls, New Brunswick, and moved to Fredericton in 2013, where she obtained a bachelor and master's in kinesiology from the University of New Brunswick. She is also a CSEP, clinical exercise physiologist, and has training in chronic disease management from York University. In her free time, she loves to read, watch movies with her partner, and her two cats watch TV too, and hike. I'll just briefly mention Lynn. So of course, as she pops in. So Lynn Duffley is a senior manager with Live Well, Bien Vivre. Excuse me. She has over 35 years experience in health promotion, working across the spectrum in programs, policy, research, and evaluation. She has a Bachelor of Science in Physical Education from St. Avex and has partially completed a Master's of Education at the University of New Brunswick. Lynn helped develop several health-related coalitions, including the New Brunswick Anti-Tobacco Coalition, the Healthy Eating and Physical Activity Coalition, and the Children's Environmental Health Collaborative. She appreciates time spent with her daughters, enjoys hiking, kayaking, and snowshoeing with her dogs. So we'll just proceed then, okay, Courtni?
Yeah, perfect. So let me just share my screen. Perfect. Yeah, thank you so much for having us today. Yeah, we'll just talk about our Live Well, Bien Vivre program. So the Live Well, Bien Vivre program offers province-wide health coaching to really help advance the mission of the Heart and Stroke Foundation of New Brunswick. And this program, Live Well, Bien Vivre, is also made possible by our funding partner, which is the Government of New Brunswick's Department of Health. So our mission here at the Heart and Stroke Foundation is truly to promote health, to save lives, and enhance recovery. And the Heart and Stroke Foundation of New Brunswick really leads the fight against heart disease, stroke, and other related chronic conditions. So within the Heart and Stroke Foundation of New Brunswick, in our health promotion sector, under our direct client care services, the Live Well, Bien Vivre program really fits in well with this mission at the Heart and Stroke Foundation of New Brunswick. So the Live Well, Bien Vivre program, we are an accessible, confidential, no-charge professional health coaching for adult New Brunswickers. And this can be a program for those who may be currently living with a chronic condition or a chronic disease, and they want to better manage that condition. But it can also be for those who maybe are not living with a chronic condition yet, but want to work on that prevention. So as long as somebody really wants to take a step in a healthy direction, we can work together to achieve those goals. And it's really important in our program that our work is really driven by collaboration. So, we really collaborate with our clients. We're client-led, people who have lived experiences, but also with different health professionals across the whole province of New Brunswick, as well as governments, researchers, and many others. And I see that Lynn has just popped on.
Hi, Courtni. Thank you so much. To all of the participants, my sincerest apologies. I wish I had a connection problem, that I could say happened, but I didn't. I actually overslept. And I feel terrible. And I thank you so much both for waiting and worrying and for Courtni to reach out and begin the process. So thanks. And Courtni, I'm going to let you finish what you were saying and I'll pick it up from there.
Yeah, perfect. No, I just, yeah, I was pretty much done. I'm not sure if there's anything you wanted to add in terms of our program and what we offer.
Great. No, it's good. We'll move on to the next slide. Courtni, do you want to, I'll let you do that since you've already, I have control. Thank you. And the great part about Live Well Beyond Vivre is the way in which it supports clients to improve their health and wellness. We look at, of course, the main behaviors associated with the development of chronic disease. And so our work is done to prevent even chronic conditions and support those through physical activity, healthy eating, mental well-being, and tobacco-free living. And the approaches that we take are foundational, grounded in research. They're unique, and our professional health coaches offer them in a variety of settings, whether it's virtual, in community, or in health clinics, and we even are working within doctor's office and community health centers. Go to the next one. Health coaching is still relatively new in Canada, and certainly we've been here for over almost 8 years in New Brunswick. The research, though, is decades old, and the most recent research review by Vivre and all showed that health coaching was defined as both client-centered, client-led, using self-discovery, client accountable and without judgment, and a mutual, and we say sort of like a two-way relationship. So the idea is that we come together as partners with our clients, actually sign a partnership agreement through the process. And lack of motivation to participate in healthy activities is 77% of our clients come to us, citing that as one of the major reasons why they can't move forward with a healthy lifestyle or making a healthy behavior change. Next. So what are the benefits of health coaching? Well, very much research has shown it helps people sustain healthy behavior change. It enhances clients' self-care skill, improves their health outcomes, especially in the areas of diabetes, heart disease, obesity, and cancer. And our participants in the program, at the end of the program, we put them through an exit survey, and they have all answer this question: would you recommend Live Well Beyond Vivre? 82% of our clients have said yes, and 18%, even before getting to the exit survey, have already recommended Live Well Beyond Vivre to a family member or friend. So a health coach guides a client to adopt health behaviors by sharing how to set manageable goals, connect to resources, develop problem-solving skills, and effectively self-manage their own health and wellness conditions, chronic conditions. And they work with them to establish an action plan, and through the course of approximately 8 to 12 hours of professional health coaching, or the relationship and the partnership that is built between a health coach and the client helps to achieve these kind of outcomes. Also, during our exit survey, the participants have a chance to tell us what is most important to them and how well they've done. And this past year, we've had great success with 100% of our clients communicating that they feel that they had achieved their wellness goals through working with a health coach. And the next one. And so this is actually where Courtni was supposed to jump in and let us know about what it really means to have a bit of an experience with a health coach. And I'll let her take it from here.
Yeah, perfect. Thank you so much, Lynn. Yeah, so I thought today we could just talk about, a couple self-care tips for pandemic well-being, as, some people could be experiencing a lot of stress and uncertainty right now, and that can cause a lot of stress, right? It's important to note that, the couple slides I'll go through are really just a small picture of what we can do within our health coaching. It's just a little taste, and once we're able to kind of work, one-on-one directly with a client, we're really able to kind of dive into you and your own health goals, right? So when thinking about, self-care tips or stress management, even starting with asking ourselves, what are your stressors, right? What are the things in your life that feel a little bit stressful? And these can be anything from, even the weather or workload, maybe family relationships, but there can also be positive stresses in our lives as well, right? Things like planning a vacation or planning a wedding. Those can be very exciting, but they can cause stress as well, right? So even thinking, what are my stressors? And once we can identify those, we have a few strategies that we can implement to, reduce that stress or even eliminate it altogether. So the first strategy we have are refuel strategies. And so these are really going to be things that are, planned activities. We're thinking ahead. It could be something you're really good at doing. It could be a hobby, a vacation. But again, something we're planning, something we do to kind of refuel our cup, so to speak, right? We can't pour from an cup, so it's important to, fill that back up. And these activities can be different for everyone, right? It can be maybe planning coffee with a friend once a week, or going to your favorite exercise class. But again, it's really important that these things are planned. And you can even start to think about, what would these activities look like for me? Maybe you're already doing some refuel activities, or you already have refuel strategies, and even reflecting on, how do I feel after that activity, right? Do I feel refreshed? Do I feel better? And another strategy that we have as well can be relief strategies. So these things are typically unplanned and they're spontaneous in the moment, typically reactive to stress, and can kind of be a nice pause button in the moment. And again, these things can vary depending on the person. It may be taking a moment and doing some deep breathing exercises, or it may be taking a moment to step away and go for a walk. But again, it's really important that these things resonate with you and they're things that you enjoy to do. It's also important to note that we may need different relief strategies depending on the type of stress that we're experiencing or the environment that we're in. So again, it can be important to think about what are those stressors for me and what strategies can I have in place for when these moments happen. Now we have a quick example. We won't go through this together today, just for time's sake, but this is an amazing example of a practice you could do quickly to relieve pressure, right? It's a really nice grounding exercise, anywhere from 30 seconds to 2 minutes. Maybe you can do it in the car or at your desk at work, but really giving yourself that time to press the pause button, slow down your heart rate and kind of feel that physical relaxation in the moment. And it's important, there may be times when you need a little bit more than self-care, or maybe you don't have as many stress management strategies in your back pocket as you'd like, but please know that you and your clients are not alone. So, really reaching out to a health coach for that support our role, truly, like Lynn said, is to, support and guide and provide that accountability to folks who are on their own wellness journeys. We have an amazing team of 10 health coaches across the whole province of New Brunswick, and we are all more than happy and excited to have those conversations and see if health coaching and the Live Well Beyond Vivre program is really a good fit for you. And this is our toll-free number and our email address as well. So again, anytime reaching out, even just for any questions, we are more than happy to connect and talk about the program and your goals and what you're looking to accomplish. Perfect. So thank you so much for your time today. I'm not sure.
Back. This is great. You really zipped through that, but you certainly hit on all the highlights for the program. And I don't remember how I found out, and that's the interesting thing about promoting these kinds of things. But it's like a well-known secret that it's available and it's free, and that you have so many health coaches around the province to help. So, and then because it was during the pandemic last year, we were able to do it by phone. And it certainly helped me at the time. I had some health issues and also, of course, the anxiety around the pandemic. And so quickly, a couple of questions. This group of health coaches sounds wonderful. Do you have a referral process or handouts that we could provide to patients?
Yes, actually we do. Every health coach has prescription pads that have our contact information on that can be given to health professionals. We actually, it's a self-referral program so that you can also just speak to a client or a patient and give them the information and pass that on. We also have posters and rack cards. You can contact our toll-free line or send an email, and we would be pleased to provide people with the information. We have it also electronically that people can use it. The way our referral process is simply using what currently exists within the healthcare system. Doctors, nurses, dietitians all have within their system have the ability to refer to external sources, and in that same mechanism, by simply asking their patient or their client if they would like to be referred and making note of it in their patient or client's file, they can even do a direct referral. And we're receiving direct referrals from a variety of health organizations, as well as physicians, bariatric surgery, cardiac care, orthopedic surgery. So it's occurring in a very natural way, working within the system of referral that a health professional currently uses. And we have it that it comes simply to us as an email, providing us with someone's name and number. We have people who are using our prescription pads and scanning them with a name and number, and then sending that scanned referral through by email. We've had individuals who will clients who will come in person to meet with a health coach, especially ones that are set up in clinics or in medical centers, and they'll walk in with their prescription pad slip like they would as if they were going to the pharmacist. So we're very open to the way in which people are referred to us, and we are actually also very willing to work with an organization, whoever the coordinator is, to find the best mechanism that works for them to be able to reach out to our entire team.
That's excellent. Thank you, Lynn. Again, we're near the end. I just want to mention, someone commented, this is so needed for everyone. Mental health is at a low time job. Great job with this. And yeah, and lots of people now starting to thank. So I want to remind everybody that I know Melanie mentioned at the beginning, there is a very short survey for you to do. And it helps us with how well we did, what we can do differently, helping to pick topics for next year. So if you could please do that. The SurveyMonkey link is over in the comments section. Melanie just posted it again. So if you could please do that. So I don't want to leave you both hanging because you probably have to go, but I appreciate again what you presented on today. Thank you very much.
You're welcome. Thank you for inviting us.
So for everybody who's still here, oh, sorry. For everybody that's still here, thanks for attending. I'm glad so many people showed up, and we look forward to your comments in the survey. As I said, it makes a big difference. Last year, I think that's what helped us decide, obviously, to keep going as well, is that people said that having a virtual symposium, that it was not all day, they didn't have to travel, they didn't have to pay a fee, was an absolute bonus. So look forward to us doing this again next year. Someone asked again about the certificate. If you're a healthcare professional, you can email me and ask for your particular certificate of attendance. If you're a student, you need to ask your instructor. And they really want to know that you've been here. So we are able to see if you've logged in and out and didn't stay. Sorry. You know what instructors are like. So there you go. And Melanie's just thanking everybody again, our sponsors, for supporting this endeavor, and we do greatly appreciate that. So once again, thanks again, and I guess we'll see you next year.